So welcome to week 12. We're almost finished. Who's excited?
Yay!
Okay. Okay. So we're on week 12, and next week I'm not sure if we're going to be over at Mary Meeting or if we're going to be at the high school. I found out that next week they're having parent-teacher conferences here. So as soon as I find out from the office, I will email you and let you know. For those of you where you are now, you're going to be just fine. It's just us here at Mount Ararat. Okay, so Daniel's here. Okay. All right, so tonight is 26 and 27, the endocrine and nervous system, and the eye, ocular adnexa, auditory, and operating microscope. A couple of things I wanted to just point out. We talked last week about the national exam. I did put that information on Evolve. Did you find it? Okay. There was the application form. There was a how to fill out the application form. So when you are done with those, you get them to Amy with the 2 dates on it that you wanted to sit for. So after next week, what I like to do is set aside 4 weeks, and then in 4 weeks, do a mock exam. So I will repeat this again next week, but what happens is we finish the class next week. The following week, you will take the pre-exam on Evolve. Once you take the pre-exam on Evolve, you then start the review. Daniel, did you bring your red book? Can I see it? Yes, you see the exam review. I had to order mine, so. So the following week, instead of coming to class, not next week, but the week after, so that's the week of school closing, week of the 15th, you will take the pre-exam on Evolve, and it's going to be this course, okay? It's going to be from this book, and it's online. It's going to be 5 hours and 40 minutes, so set aside 5 hours and 40 minutes. When you're done that, you will send me your grades. Now, there will not be any way to print off the pre-exam when you're done with it the first time to see how you did. You just do it, because I want to see what you got from the class to take the pre-exam. Okay? Then you start reviewing Unit 1 and part of Unit 2 in this book. The same time, the following week, you take the post-exam. Send me your grades again. Then you go in and you finish Unit 2 and Unit 3. And then we usually come together on that 3rd week and do an exam review. So I think that puts us to the first week of March, maybe. Okay? So same night every week. Just like instead of coming to class, you're going to do the pre-exam. You're going to do the post-exam. So you're going to have to set aside time every day to do the unit work. The unit work is easy. It goes through every system. It gives you 10 questions at the end of every section, and the answers are in the book. So you have the opportunity to check your work. When we come back for the exam review, I will give you tips and tricks to get through the exam. By that time, we should have a mock exam date set up. As I said last week, it will be a Saturday. It will be 5 hours and 40 minutes. And I will probably more than likely schedule it here at Mary Meeting because they have a great size room to hold the amount of students that should be attending. Again, it's a mock exam. If you can't make it, then I suggest you set aside time on your own to do the 5 hours and 40 minutes. But this time it's going to be out of the book. All right? Once you do it in the book, you will then go on to Evolve and put your answers in, and it will give you your score. Now, after you take the post-exam, you do have the opportunity to review both the pre and the post and the rationales that on the answers you got wrong. On the mock exam, we'll go over some of the stuff at the mock exam. We'll actually go over the answers so that you can see how you did right then and there. You can still go back, and if you want to do it online again, to try and increase your speed or your grade, you can do that. That's the nice part about this. And then I encourage everyone within a month of that mock exam to sit for the actual one. Okay? I believe that works best for everybody. It gives you still, you figured at least 8 additional weeks to really work on some of the areas you think you need to work on. So we'll be done class February 11th. By middle of April, everyone should have a date to sit for. Okay? So I encourage you now to take your exam applications, print them off of Evolve, go on to the AAPC website, and pick a few dates. And when you go on to the AAPC website, you will, I think it's locate an exam, and then I think you choose CPC, and you can put Maine or New Hampshire or Massachusetts if you want to travel. Okay? They're usually pretty local: Bangor, Lewiston, Portland, so really not that far. I believe I also have this same information on Evolve underneath the national exam questions, but I will repeat it again next week. Any questions? Okay. It is 5 hours and 40 minutes, but the simulation is a good simulation to give you an idea of what to expect. If you do not have the CPC physician exam review on Evolve, just send me an email and I will make sure that you are set up for it. Okay? Fran, you have yours unwrapped. Can you look on the inside cover and tell me if you have a silver scratch box that you need to scratch off?
I do. Yep.
Okay. So once I enroll you in the course, just like you did with the Buck book and you're going to scratch off that silver box and it will give you a code to put in so you can access it.
Okay.
The other thing is you might have Format A and Format B to choose from when you go into Evolve to take these exams, these Evolve exams. I would choose format A. Now, if you go in for the pre-exam and you chose format A, when you go in to take the post-exam, you want to also choose format A. You don't want to go between the two because it will mess you up. If you want to go back afterwards and take format B, for practice, go right ahead. But I would recommend format A. All right, I think that covers it. All right. And I mentioned to everyone last week, I think, about your HICPIC books, or a few weeks ago. It's really just tabbing the exact same items, your modifiers, your drugs and chemicals. One area I would like to draw your attention to in your HICPICs remember early on when we were doing the ICD-10 book, or CBT book, sorry, and I said you probably want to reference in your CPT book that you can find these G codes for Medicare patients. So on page 165 in your HICPIC books, you'll see that you have G0008 for administration of influenza virus vaccine. G0009, administration of pneumococcal vaccine. So these are administration codes. These would be used for Medicare patients. So instead of using those codes in your CPT book, you would come here to your HICPIC books and use the G codes. Same thing with the G0101, cervical or vaginal cancer screening. G0102, prostate cancer screening. G0104, colorectal cancer screening. G0120, colorectal screening alternative to G0105. Again, these are all Medicare approved codes. These would be the types of codes you would use if the Medicare patient was coming in for screenings or administration of a flu vaccine. All right, everyone has that? All right. Turn to page 739 in your textbook. And page 364 in your CPT book. with the endocrine system. What are the 4 endocrine glands that are included in the endocrine system subsection? What are the 4 endocrine glands included in the endocrine system subsection?
Thyroid, parathyroid, thymus, adrenal.
Yes. Thyroid, parathyroid, adrenal, and thymus. Now, if you look in your CPT book on page 364, the endocrine system is pretty much cut and dry. Okay, it's not a very big section, as you'll notice. So, a lot of the notes that you really want to make in your endocrine system or highlight would be what type of procedure. Is it partial or is it total? So 6000 code is simply just an incision and drainage. The 60210 is a partial. The 60220 is a total. 60225 is a subtotal. And the 60240 is a total or complete. 60252 is total or subtotal. Turn the page to 366 in your CPT book, and you'll notice that code 60600 is without excision. So without excision. 60605 is with excision. So those are the types of main terms that you want to highlight or underline. Again, these are to stick out at you so that as you're looking up your homework or doing your exercises, these are the things that are going to jump out at you. All right, so there are 9 glands in the endocrine system. And you'll see by the diagram there on page 739, it gives you a perfect diagram. Really good one to follow. Of the 9 glands, there are only 4 that are included in this subsection, as Daniel noted for us. The thyroid, the parathyroid, the thymus, and the adrenal. If you were to look for the pituitary and the pineal, you would look for those in the nervous system. The pancreas is in the digestive system, and the ovaries and testes are in the respective genital systems. If you were to look up what CPT codes pertain to the endocrine system in your manual, it would be code 60000 through 60699. Then you'll notice in your CPT book that you have 2 subheadings. It's divided into 2 subheadings. The thyroid gland, and then the parathyroid, thymus, adrenal glands, pancreas, and carotid body. Those are the red highlighted headings in your CPT book. Page 740 in your textbook. The carotid body, what does the carotid body refer to, Darcy?
I don't know.
That's all right. The carotid body refers to the area that is adjacent to the carotid artery. And this is a site where you can find tumors. When you hear of tumors, most often you will hear them being referred to around the carotid body. The carotid body is rich in capillaries, and it acts as receptors of the carotid arteries. So what would be the code for tumor excision? What is the code for tumor excision in the carotid artery? Fran?
With excision of the carotid artery, is that what you said? I'm sorry.
Yes, tumor excision.
Okay. 60605 is with the artery.
Yes. Okay. And then we look at the thyroid gland. There are two lobes in the thyroid gland. And your code descriptions will often refer to, as I mentioned before in your CPT book, partial or subtotal, which means something less than total. An excision would be removing the problem side of the gland, the isthmus, and the majority of the opposite lobe. Total would mean all. A lobectomy would mean partial. And a total thyroid lobectomy would be solitary nodules, follicular adenomas, nodules, and goiters. So your code descriptors in the excision category often will refer to that partial or subtotal that I mentioned earlier. So what is the code for a thyroid incision? Darcy, thyroid incision.
$60210.
No, a thyroid incision. Incision. Go up. Incision.
60100.
Nope, you're still under excision. So an incision would be...
Yeah, 60000.
Yes, 60000.
The only one I didn't highlight.
That's what we do. Exactly. It's too obvious. We look over it real quickly. Okay? All right. So we're in and out of the endocrine system that quick. It's just those few pages. And the highlighted things that you want to know, as I mentioned, partial or subtotal or total. So we can move right into the nervous system. The nervous system is on page 742 in your textbook. And in your CPT book, we start at 367. And you'll notice that you have some nice diagrams on page 368 and 369 in your CPT book. But this nervous system starts on page 370 in your CPT book. So what I want you to pay attention to here is the nervous system is divided anatomically. We have the skull, the meninges, and the brain. That is your first heading. Then we move on to the spine and the spinal cord, and then into extracranial nerves, peripheral nerves, and the autonomic nervous system. The skull, meninges, and brain. The categories that you're going to find here, as we have learned throughout this book, are injection, drainage, or aspiration. Now these are a little bit different than some of the other categories, but we have seen them throughout. You also will have twist drills, burr holes, or trephine. The meninges is made up of 3 layers of connective tissue membranes that actually surround the brain and the spinal cord. So what is a twist or a burr hole? Daniel, what is a twist or a burr hole?
Wouldn't those be holes made by drills?
Yes.
To gain access to.
Yep. They are trying to, on page 744 in your textbook, they are trying to gain access to the brain, and they do so by punctures, twists, or burr holes. Conditions that might require openings into the brain would be to relieve pressure, insert monitoring devices, place tubing, or inject contrast material. So what is the benefit of using twist or burr holes? It is so that the skull stays intact except for the small openings that are made. Your procedures for craniectomy or craniotomy will be reported using codes 61304 through 61576. And these procedures actually deal with the actual incision of the skull, with possible removal of a portion of the skull to open the operative site for the surgeon. When you're doing a grafting procedure that might follow a craniotomy, you would code it separately as it's part of the original procedure. Skull base. Surgery of the skull base, bottom of page 744. Surgery of the skull base, page 372 in your CPT book. The skull base is the area at the base of the cranium. You'll notice that your skull actually has like this little divot here. And then your spine comes down. That would be your skull base. All right. Lesion removal from this area would be very complex. You're going to find that, as you can see right in your CPT book, there are extensive category notes. So as I mentioned before, read the before, the middle, and the after. Surgical management of the lesions in the skull base is very tricky. Often it would involve more than one surgeon from different specialties working during the same operative session. So again, you're going to find extensive notes throughout here, so please be aware of those when you're coding. Some of the terminology that you want to be aware of in your CPT book is, what is the approach of the procedure? How is the surgeon gaining access to expose the lesion? What is the definitive procedure? What is being done to the lesion? And then repair, construction procedure. Are those reported separately? And if so, they're reported separately only if there is extensive repair. So your approach procedures are going to be reported using codes 61580 through 61598. So if you look at codes 61580 through 61598 in your CPT book, you'll notice that these are your approach procedures. And they tell you right in your CPT book at the top there, approach procedures. Your approach procedure and your definitive procedure are coded separately. If the same physician performs both the approach and the definitive procedure, both would be coded. The lesser procedure usually will have the modifier 51, and the lesser procedure is the approach. Who can tell me why? Fran, why do you think?
I would imagine probably because the approach is how you get there, but the actual procedure is so much more involved than just getting in and,
Correct.
you know.
Correct. So if we had two surgeons, we would use a modifier 62, and a surgical team, we would use modifier 66. So let's say, for example, that we were doing a removal of an intradural lesion using the middle cranial fossa approach. We would use code 61590 as the infratemporal preauricular approach procedure, which is middle cranial fossa, and 61608 as the definitive procedure of intradural resection of the lesion. And you would report both of those. The cerebrospinal fluid shunt, or CSF shunt. Over on the bottom of page 745 in your textbook. The CSF shunt is on the bottom of page 379 on the right-hand column. The CSF shunt is used to drain fluid. The codes here describe the placement of the devices, the repair, the replacement, and the removal of those shunting devices. Over on page 746 in your textbook, the spine and spinal cord, these are divided on the condition and the approach. So some of the other important coding considerations that you want to pay attention to with the spine and spinal cord are unilateral or bilateral procedures, multiple procedures. So if it's unilateral or bilateral, you would want to use modifier 50. If it's a multiple procedure, use modifier 51. If we are going to use radiological or fluoro guidance, those are going to be reported separately. You will notice that there are many codes in the nervous system that involve conditions responsible for the procedure. For example, abscess, cyst, hematoma, foreign body, tumor. And what you will also see along with these is the technique that is involved in the operation. Okay, so on page 381 in your CPT book, 380 and 381, you'll see spine and spinal cord, injection, drainage, or aspiration. Again, you have a lot of notes to pay attention to, but also look for what type are they working on. Is it an abscess? Is it a cyst? Is it a hematoma? Is it foreign body? Is it a tumor? And then what is the technique used for the operation? All right, introduction and injection of an anesthetic agent, diagnostic or therapeutic. Page 749 and 750 in your textbook. This is where the codes that you're going to see here are for nerve blocks, facet joint injections, and epidural injections that are used to provide pain relief. So what is the result of a nerve block? Shauna, what do you think? Just guess.
So you can't feel it?
Loss of feeling, exactly. All right, so people with debilitating pain may undergo an injection to cause destruction of the nerve, to cause permanent loss of feeling in that specific area of pain. Pain. All right, what is a lumbar puncture? 748, lumbar puncture. Darcy, what is a lumbar puncture?
Essentially it's a spinal tap.
And why would it be performed?
I guess to, I don't really know.
Daniel, you want to guess?
To collect some of the spinal fluid.
To collect some of the spinal fluid, yes. Okay. Carpal tunnel release. Carpal tunnel release. Over on page 751. Fran, what's carpal tunnel release?
It's when they go into your wrist, if you've got carpal tunnel syndrome, they actually cut that so that you have more freedom of movement. You don't get the tingling and the numbness anymore in your hands.
Yes. All right, I'm going to give you all a critical thinking question. Mike has surgery to excise a lesion found at his skull base. Dr. Morris is the surgeon, and he performs both the approach and the definitive procedure, along with a straightforward repair of the skull. Would these procedures be reported using a bundled code or two separate codes? Shauna?
Two separate codes.
Yes, two separate codes. Would any modifiers be necessary? Fran?
No.
Why?
Because they're two separate procedures.
Right, but if the same provider is doing it, you want to put a modifier on the lesser procedure.
Oh, that's right.
Remember?
I'm sorry, yes.
That's
Yep,
okay.
because he's the same person.
Right, same person, and the approach is considered the lesser of
Lesser
the
of the two.
definitive.
Yep.
Okay, and would the repair to the skull be made on closure to be reported with a separate code? What do you think, Daniel? The reconstruction of the skull base would not be reported because it's a straightforward procedure. So all we are coding here is the approach and the definitive procedure. Okay? Excellent. Any questions in that chapter? How did everyone do with the end of chapter stuff, okay? No questions? Oh my gosh, you guys are so easy. All right then, let's move on to chapter 27, eye and ocular adnexa.
Eyes are gross.
Shana says eyes are gross. Okay, so in your textbook, we're on page 755. In your CPT book, page 403. Now, what are the 4 areas of the ear that are included in the auditory system subsection? Fran, what are the 4 areas of the ear that are included in the auditory system subsection?
Oh dear. The external ear, the middle ear, the inner ear, and the temporal bone.
Yes. And the middle fossa approach. All right, what are the subheadings of the eye and ocular adnexa? What are the subheadings of the eye and ocular adnexa? Darcy. Your subheadings are in red.
The eyeball, the anterior segment, the posterior segment, the ocular adnexa, conjunctiva.
Yes. Excellent. Conjunctiva. All right. What is a myringotomy? Shauna, what is a myringotomy?
I don't know.
Daniel, what's a myringotomy?
I have no idea.
Anita, what is a myringotomy?
Oh, okay. Yeah.
There you go.
The eustachian tube.
Incision into the tympanic membrane and reinflation of the eustachian tube. All right. So terminology that is extremely important when it comes to the eye. You'll notice on page 402 in your CPT book, they have an excellent illustration of the eye anatomy. I would make sure you know where to find this illustration when you need it. It will be very helpful when you're doing your exercises or the exam for that matter. Some of your categories are going to be a little different in the eye. For example, the subheading eyeball has categories for both the removal of the eye and removal of foreign bodies. Your codes are divided anatomically. So your examples would be eyeball, conjunctiva, anterior segment, posterior segment, and ocular adnexa. Some of the codes are specifically for patients previously operated on, so pay attention to the wording. You will have specific codes for re-operations. You will see that there is a lot of bundling going on in these codes, and you want to pay attention to the descriptors. So for example, the subheading posterior segment, prophylaxis category, the notes indicate the following descriptors are intended to include all sessions in defined treatment period. That's under the posterior segment. So at the bottom of 755 over to 756 in your textbook, we're going to talk about the removal of the eye. So to report evisceration, this is the removal of the contents of the globe. So what's being performed? Evisceration. And you would want to know, is it being done without an implant or with an implant? Enucleation. What is enucleation? Enucleation is where the removal of the eye, but leaving the orbital structures intact. Accentuation. This is removal of the eye, the adnexa, and part of the bony orbit. Now, if there's any associated skin grafting that needs to be done, that would be reported separately. Why is that? Skin grafting falls into the integumentary system, right? Removal of foreign body. Over on page 757 in your textbook. Removal of foreign body. Again, you'll find that there are a lot of notes here. This is removal from the external or intraocular. They use a slit lamp to be able to see. And this is a microscope with high intensity light source. It focuses long, narrow beams of light so that the physician can see what they're doing. Different codes are going to be used with or without the slit lamp. So pay attention to your code descriptions, with or without slit lamp. So for example, 65220 is foreign body removal without the slit lamp. 65222 is foreign body removal with the slit lamp. And it tells you right in your textbook, there's page 757 at the last line of the paragraph. Also, pay attention to whether or not the codes are for the foreign body removal are external or intraocular. Over to page 758, the anterior segment. The anterior segment. This includes the cornea, the anterior chamber, the anterior sclera, the iris and the ciliary body, the lens, the intraocular lens procedures, and any other procedures. What is the anterior segment? Fran, what is the anterior segment?
I'm going to guess and say it's the front part of the eye.
It is. And what is the cornea?
In front of the iris.
That's the surface of it.
Layer. It's a layer.
Yes. Okay.
Wasn't sure if you were asking me, sorry.
Yep.
What's that?
Okay,
So,
thank
what
you.
is a keratoplasty? Keratoplasty. Anita, what is a keratoplasty?
Repair of cornea.
Yes, repair of the cornea. So when we talk about a penetrating keratoplasty, we're talking about a full thickness of the cornea removal. And it's usually replaced with a donor cornea. What is aphakia? Darcy, what is aphakia?
Absence of the lens of the eye.
Yes. And Shana, what is a pseudophakia?
Presence of an artificial lens.
Yes, presence of artificial lens after the cataract surgery. All right. The anterior chamber. The anterior chamber is that fluid-filled space that's behind the cornea and in front of the iris. What is a paracentesis? Daniel, what is paracentesis?
That's when you remove the fluid.
Yes, removal of the fluid in the eye. And what is used to do that? It would be a needle. A needle is inserted into the anterior chamber and the fluid is then withdrawn. What is a goniotomy? A goniotomy, Fran?
It's when it's a procedure to get rid of that cloudy lens if you have glaucoma.
Yes. Yes. Okay. And adhesions. We have adhesions on the posterior and the anterior. The posterior are the adhesions of the iris to the lens, and the anterior is adhesions of the iris to the cornea. The anterior chamber also is where you will see the trabeculotomy ab externo. This actually will involve the trabecular net meshwork, which is the iris scleral junction, and it's drained of the aqueous humor. The surgery then reshapes or punctures the meshwork as a treatment for that glaucoma or trauma. The iris and ciliary body. What happens with the iris and the ciliary body? The ciliary body is located behind the iris. We would see an iridectomy performed for this area, and if so, it is to remove a lesion, treatment of glaucoma, a laser iridotomy or iridectomy, and a photocoagulation. Now, I'm going to tell you that there is a question on the Evolve exam, and you want to make sure that you answer 3 when it comes to lenses. And that's all I'm going to tell you. On Evolve, you have a question in regards to lenses, and the answer should be 3. All right, moving on to cataracts. Nuclear cataracts are the most common. They're usually at the center of the lens, and this is due to aging process. Your cortical cataract, it forms in the lens of the cortex and it extends outward. This is usually common in diabetic patients or diabetes. Your subscapular cataract forms at the back of the lens. If you did an intracapsular procedure, it would be an ICCE. If you did an extracapsular, it would be ECCE. Removal and lens placement, as I just mentioned, is either extracapsular or intracapsular. The extra is partial removal, the intra is total removal. Phacoemulsification is where there's a small incision into the eye. They introduce a probe. They then use high frequency waves to fragment the cataracts, and lens are placed through the same small incision. So, what are the 3 types of extraction? Extracapsular, intracapsular, and phacoemulsification. The posterior segment, these codes include the vitreous procedures for removal of the vitreous humor of the eye, the repair of the retinal detachment, and the destruction of the lesion of the retina or the choroid. What is a strabismus surgery? Fran, what is a strabismus surgery?
Whoops. Oh, you can see us now. It's to correct an eye that's not focused in the center.
Yes, it corrects that muscle misalignment. The horizontal muscles are the ones that move side to side. The vertical muscles are the ones that move up and down. Your codes are going to be divided on the type of repair and the number of muscles repaired. On page 760, the eyelids. The eyelids, we see some procedures. A blepharotomy. A blepharotomy is incision into the eyelid for drainage of an abscess. A blepharoplasty is repair of the eyelid. These codes would be found in your integumentary system. The codes that you see here in the eye and ocular adnexa, our selection of the code will depend on the technique that is used for the repair. We also will see that there are hick-pick modifiers. I pointed out these modifiers to you early on in the course. You'll find them also in the front part of your CPT book. E1, upper left eyelid. E2, lower left eyelid. E3, upper right eyelid. And E4, lower right eyelid. All right, critical thinking question. Jenny undergoes partial removal of a cataract on one eye. What code would be used to report this procedure? Partial removal of cataract on one eye. What code? Any guess, Fran?
Still looking.
66830.
No.
66830.
No, because we're not talking about the lens removal. We're talking about a lens procedure. So it would be the partial removal of a cataract on one eye. It is 66984. So look at 66984. And we're talking about a lens procedure, not the actual removal of the cataract. Okay?
Yeah.
All right. Any questions about the eye before we move on? All right, let's move on to auditory. Auditory, page 761 in your textbook, and page 417 in your CPT book. Now, the auditory system, the codes are going to be divided by external ear, middle ear, internal ear, and temporal bone, which is middle fossa approach. The outer and middle ear function is the conduction of sound waves through the ear. Your inner ear contains structures that receive the auditory waves and then relays them to the brain. And then we have an operating microscope. So which codes in the CPT manual refer to the auditory system? Anissa?
Auditor. Okay, 69000 to 69399.
69970.
70.
69970. Okay, so the terminology that we want to be aware of for the auditory system is mastoid and tempo, or timpano. You'll notice that with the external ear, again, the divisions of the auditory system are external, middle, and internal ear. You'll notice that the illustration you have on page 761 breaks those open for you so that you can see them more clearly and you understand what is in each of those sites so that you have a better visual. So the categories that are then listed under each subheading will include introduction, incision, excision, removal, repair, and other. And then as you see underneath excision, you'll have removal of the foreign body, repair, and other procedures. On page 762, the external ear. Underneath this section, we see incision and excision. When we talk about incision, it's all about drainage of abscess or hematoma. And we want to know, is it simple or is it complicated? So, if you look at 69000 in your CPT book on page 418, 69000 is drainage. Drainage of ear abscess or hematoma. And it's simple. The next code underneath is complicated. Your excision code will be your biopsy code. So 69100 is biopsy of the external ear. 69105 is biopsy of the external auditory canal. Your 69100 is simple repair, and your 69120 is complete. So again, what are the words that are going to stick out at you? Highlight those words. So simple, complete, biopsy. The physician will also indicate if it is simple or complicated, so you can pay attention to that in your reports. Removal of foreign body, bottom of page 762 in your textbook. This is based on with or without general anesthesia. So removal is with or without general anesthesia. Impacted cerumen with instrumentation. If it's one ear, it's 69210. If it's both ears, 69210 modifier 50. So again, your foreign body removal is based on whether the general anesthesia was used or not. An autoplasty. An autoplasty, on page 763, autoplasty, top of the page, is for protruding ears. This may or may not decrease the external ear size, and if you do both ears, you would use a modifier 50. And Repairs of the external ear may actually be performed due to stenosis or due to injury or infection or a congenital defect. So be careful in this area not to unbundle your procedures. All right, the middle ear, page 763. The eustachian tube connects the middle ear to the back of the throat for drainage. The fluid collects in the middle ear when the tube malfunctions. You notice that newborns or young children have this, and that is because that eustachian tube is not developing as quickly as they might be. So you'll notice that they get a lot of ear infections. And it simply needs to help that drainage. So, when you see them pulling on their ear, what they're actually trying to do is, number one, it hurts. But they're also trying to get that moving, get that flow of fluid going. So fluid will collect in that middle ear, and then it prevents the air from entering the middle ear and the pressure builds. They sometimes can treat it with antibiotic, but then you might end up having surgical intervention, which would be a myringotomy or a tympanostomy. The myringotomy is where they have the incision into that tympanic membrane to relieve the pressure and drain the pus. The tympanostomy is where they do an incision and they place a little PE tube, okay? So it's really, really small. It's probably like the tip of this pencil or even smaller. If you wear earrings and you have those little rubber plastic backings to earrings, it could be that small. You figure it has to be really small to fit into their little ears to help expand that canal to help the drainage. And what this does is it gives pressure equalization and it repairs the eardrum and the hearing mechanism. And what happens is that those little tubes can fall out all on their own. You don't even have to worry about them coming out. And you usually have follow-up visits to make sure that they're still in there or they've come out. And your myringotomy is actually included in a tympanostomy. So pay attention to any description or wording when you're reading reports, because a tympanostomy will include the myringotomy. Also with the middle ear, you will have a canaloplasty or a canaloplasty. This is reconstruction of the external auditory canal. The codes are based on stenosis or congenital defect. And you want to be careful here because the canaloplasty and the canaloplasty are bundled into some of the middle ear repair codes. So take a look at 69631. 69631. 69631 on page 420 in your CPT book. You'll notice it's a tympanoplasty without mastoidectomy, including a canaloplasty, a tichiotomy, and or middle ear surgery. Initial or revision without ossicular chain reconstruction. Okay, so that's a canaloplasty. So just be cautioned that you might find bundled into some of those codes. The inner ear, over on the bottom of page 764. The labyrinthectomy, this is the incus and the stapes are removed. The codes are based on the approach. Is it a transcanal or a post-auricular? What is a post-auricular? It's actually behind the ear. Your incus and stapes are the ossicles of the ear. So those are the small bones in the inner ear that actually aid in hearing. During a labyrinthectomy, the incus and stapes are removed and a prosthesis may be inserted to replace these. Again, pay attention to these codes because they are divided on the approach that is used. Introduction, at the bottom of page 764, introduction. What is a cochlear device implant? Darcy, a cochlear device implant, what is that?
It's a hearing device. It's to help with hearing loss.
Yes. Yep. And it's a computerized device. It will restore partial hearing. It's a receiver that is on the outside of the skin behind the ear, just over the site of the transmitter. The transmitter is implanted under the skin, and the sound processor is connected to an electrode implanted in the cochlea. The temporal bone in the middle fossa approach, over on page 765. The surgical approach here is used with the repair of the vestibular labyrinth nerves, the decompressed facial nerve, the decompressed internal auditory canal, and the removal of neoplasm from the temporal bone. The middle fossa approach, that's what it's called, the middle fossa approach. This is what is used to excise the acoustic neuromas and to decompress that facial nerve and repair the nerve in the vestibular labyrinth. Operating microscope. Fran, what is the operating microscope?
It's one that can see really tiny, tiny detail, and they use it in surgery in very small areas like ears and other things.
Right. It's also in addition to primary, you want to make sure that you code it in addition to the primary procedure that is performed. So unless the primary procedure description includes the microsurgical technique, make sure that you pay attention to the descriptor in the report. You want to make a note that following 15758 is the statement that says, do not report code 69990 in addition to code 15758. So take a moment in your CPT book and go to code 15758. Page 88 in your CPT book, 15758. In parenthetical note, you will see it says do not report code 69990 in addition to code 15758. Make sure you highlight or underline that. That is an add-on code, and it should only be used when with the primary procedure. So 69990 is an add-on code. Pay attention to your notes here in the operating microscope in your CPT book It states clearly when this is a billable service and when it should be bundled into the main service. On page 422, it clearly states. All right, how did everyone do with those exercises? All right, let's go ahead and take 5 minutes and we'll come back and do some of the workbook. All right, are we all back? Excellent. Okay, so no questions? Really? Okay. I'd like you to take your CPT book for a moment. We're going to go over some codes and what I think would be important for you to highlight or underline. And then we'll go into the workbook. So as I mentioned on page 364 in your CPT book, the incision code 60000, simply that it's an incision and drainage. As I said on 60210, partial. On code 60220, total. 60225, subtotal. 60240, total or complete. 60252, total or subtotal. And then over on, for code 60600 on page 366, without excision, and code 60605 with excision. Again, pay attention to your diagrams. If you need to make notes, these are the places to make it. Over on page 370, underneath the nervous system. Code 61000 is done on an infant, and it's the initial. On code 61050, put cisternal in parentheses. What is cisternal? Fran, what do you think cisternal means?
It goes through the base of the skull.
Yes, base of skull. So in parentheses, put cisternal in parentheses, and off to the side, base of skull. And this is done without injection. So without injection. Code 61055. With injection. All right. Down to twist drill or burr hole. Okay, you might want to just write underneath that or at the top, relieve pressure. Relieve pressure. Because when you're sitting through an exam, you want information that's going to stand out for you. So you're not sitting there thinking, oh my gosh, what does this mean? Anything you can do now to make notes in your CPT book or your ICD-10 book to help you with that process is going to be important. Now, it doesn't mean recreate the whole terminology dictionary in your book. It just means have little tips and notes to yourself so that, as I've been telling you all along, this stuff sticks out for you. Okay? What you're going to find as you move from code 61105 to 61140 is that each one becomes more extensive. So as you go up in codes, it's going to become more extensive. Ventricular. What does ventricular mean? Anitha, ventricular. Code 61105. What does ventricular mean?
110. Ventricular.
Ventricular.
Ventricles. That's the nerve, I guess. No. Oh, upper part of the head.
It's the top of your head, yes.
Yeah.
Top of your head. Okay? Again, ventricular, top of the head or top of skull. $61,108 is evacuation and drainage. 61120 is including injection of gas, contrast, media, dye, radioactive material. 61140 is biopsy of brain or intracranial lesion. Code 61250, exploratory. This is exploratory. Next to craniectomy or craniotomy, in parentheses, put the word bundled, because these are bundled codes. You're going to find these are bundled. Now let's turn over to surgery of skull base on page 372. Right there in that paragraph, the procedures are categorized according to. They are categorized according to, and I just highlighted approach procedure, definitive procedure, repair and reconstruction, because those are the three categories. So, the approach procedure is what? It's how they open. So you might want to make a little note above approach procedure that says how they open. And the repair and reconstruction procedure is what? How they close. Closure. And off to the side here to approach and definitive procedure, just put a note to report separately. Okay, so right there, approach procedure and definitive procedure, a little bracket that says report separately. So you remember that they are reported separately. They're not bundled. All right, down underneath repair and reconstruction procedure paragraph, you have a comment that says, for primary closure, see the appropriate codes, because when you're doing a closure, it comes out of the integumentary section. So you need to be reminded of that. For primary closure, see the appropriate codes. On the bottom paragraph, that very last line, it says, each surgeon reports only the code for the specific procedure performed. The very last line, each surgeon reports only the code for the specific procedure performed. Over on the next page, at the top of the left-hand column, if one surgeon performs more than one procedure, then both codes are reported and you add the modifier 51. Highlight or underline that however you need to. What I would also add here is that it is 62 for 2 surgeons and 66 for a team. So just off to the side or at the top somewhere, just add 62 for 2 surgeons, 66 for a team. For code 61580, the note you want to make to yourself there is that this is not used if one surgeon does all 3. Over on page 376 in your CPT book. Surgery for aneurysm, arteriovenous malformation, or vascular disease. The very first thing you want to highlight or underline is that this includes a craniotomy. Includes craniotomy. What you want to pay attention to for codes 61682 through 61692 is the site and the approach. And is it simple or complex? All right, over to page 379 in your CPT book. The cerebrospinal fluid shunt. Okay, if you remember that this is a drainage device, you're all set. If not, make a note to yourself that this is a draining device. On code 62190, highlight creation of shunt.
What page was that again?
On page 379 in your CPT
okay.
book, bottom right-hand corner. 62190, highlight creation of shunt. 62194, replacement or irrigation. All right, turn the page to 380. For code 62223, you can simply refer to that diagram so you see what is being done. Spine and spinal cord. What you want to pay attention to here is what is the condition and the approach. What is the condition and the approach? So in your reading of the notes here, when it talks about for code 62263, 62263 describes a catheter-based treatment involving targeted injection of various substances. And further down in that paragraph, the last sentence, code 62263 is not reported for each adhesive treatment, but should be reported once to describe the entire series of injections, infusions spanning 2 or more treatment days. On code 62263, multiple adhesiolysis sessions, 2 or more days. These codes are day driven, so code 62264 is 1 day. Over on code 62270, what is a spinal puncture? Fran.
That's the lumbar puncture where they go in with a needle, like
Right.
a spinal tap.
Correct. So it's also known as a spinal tap. 62272 is therapeutic. Six 2273 is an epidural injection. And what is known to happen with this is a spinal headache. So make a note on the side, spinal headache. Over on code 62290, page 382. Code 62290. This is an injection procedure. And it's for lumbar. 62291 is cervical and thoracic. Over on code 62310, 62310. You want to make a note for yourselves that this is not for an OB patient. 62310, this is not for an OB patient. You have little coding tips throughout your book where you want to pay attention to those. Okay, coding tips for in your CPT book. Talked about those two. All right, on page, let me see here. Over on page 394 in your CPT book. Code 64612. Code 64612, page 394. This can be also for Botox. 64612, this can be for Botox. Over on the bottom left where it says destruction by neurolytic agent. This is permanent loss of feeling. Permanent loss of feeling. Destruction by neurolytic agent. Permanent loss of feeling. Over on page 396, underneath neuroplasty, exploration, neurolysis, or nerve decompression. Highlight neuroplasty as the surgical decompression or freeing of intact nerve from scar tissue. Over on code 64716. This is for the cranial nerve. 64716, cranial nerve. 64721 is carpal tunnel. Code 64721, carpal tunnel. Over on page 398, neuropathy. Okay, it's that time of night. Code 64831. Neuropathy, okay. Suture of digital nerve, hand or foot, one nerve. So 64831 is one nerve, hand or foot. 64832 is each additional nerve. Code 64836 is the ulnar motor. 64836, ulnar motor. And 64837 is each additional nerve. Okay, over on page 403, eye and ocular adnexa. Page 403. I believe you already got these. The evisceration without implant, code 65091, without implant. 65093, with implant. 65103, muscles not attached. 65114, free full thickness. Underneath secondary implant procedures, that first line, that first sentence there, you have two separate things going on. The first one is that the ocular implant is an implant inside the muscular cone. And the second thing is an orbital implant is an implant outside the muscular cone. So ocular is inside, orbital is outside. 65130 is the insertion of ocular implant secondary. Code 65205, removal of foreign body. This would be something like a wood, metal, or splinter. Code 65220 is without a slit lamp. Code 65222 is with a slit lamp. Code 65270 is repair of laceration conjunctiva. Turn the page Under cornea, 65400 is excision of lesion. 65410, biopsy of cornea. Okay, how many of you remember what aphakia and pseudophakia mean? Okay, over on code 65730 through 65755, that's what you have there, is aphakia and pseudophakia. The aphakia is absence of the lens of the eye. And the pseudophakia is the presence of artificial lens after cataract surgery. So code 65730, 65750, and 65755. If you don't know what those mean, you want to make a note to yourself. Aphakia, absence of lens of eye. Pseudophakia, presence of artificial lens after cataract surgery. Over on page 405, underneath the anterior chamber, code 65800 is paracentesis. 65810 is removal with or without air injection. 65815 is removal of blood with or without irrigation. Code 65865 is severing adhesions. Six 5920 is implanted material. 65930, removal of blood clot. 66020 is a separate procedure. Code 66130, excision of lesion. Code 66150, fistulization of sclera for glaucoma. Six 66600, underneath iris and ciliary body, is removal of lesion. Over underneath lens on page 407, 66820 is the membranous cataract. Six 66821 is the laser surgery, one or more stages. 66825 is repositioning. Code 66830 is removal of secondary membranous cataract. So in code 66820 you had decision. In code 66830 it's removal. 66840 is removal of lens material by aspiration technique. Code 66920 is intracapsular. What you want to make note of here is that means total. Intracapsular means total. 66940 is extracapsular. That means partial. 66940 extracapsular means partial. Right next to intraocular lens procedure, make yourself a note, this is for cataracts. Intraocular lens procedure is cataracts. And again, these are complex, these are total, these are partial. Over on page 409, 67113 is repair of complex retinal detachment. Turn the page, code 67311, 67311, strabismus surgery. Turn the page to 412, underneath eyelids, excision and destruction. Highlight the parenthetical note that says for removal of lesion involving mainly skin of eyelid. Put a note beside that that says skin codes. These are your integumentary codes, your skin codes. On the next page, 413, code 67850. This is destruction of lesion of lid margin. If you're going to do a Mohs microsurgery, you want to see code 17311 through 17315. So code 67850, destruction of lesion of lid margin. For Mohs microsurgery, C17311. On page 414 under reconstruction, page 414 under reconstruction, 67930, suture of a recent wound, eyelid involving lid margin. Partial thickness. Code 67935, full thickness. Code 67938, removal of embedded foreign body. Okay, over on page 415, underneath the code 68761, bi-plug each. So the lacrimal punctum, this is repair of that plug. You want to know each. All right, page 418, auditory system. Drainage of external ear, simple. 69000, simple. Code 69005, complicated. 69020, external auditory canal. So in 69000, we had external ear. In 69020, we have external auditory canal. 69100 is biopsy. 69110 is excision. Code 69210. Code 69210. This is not an irrigation. This is not an irrigation. This is where they use one of those little currents. So it's a little instrument. It's really small. It fits inside the ear canal. And they use that to dig out earwax or something. So not an irrigation. Over on page 419, middle ear. Next to middle ear, you want to put in parentheses for yourself, myringotomy included in a tympanostomy. Middle ear, myringotomy included in a tympanostomy. All right, over on code 69424, this is a tube removal. This is done in the OR. So make yourself a note that this is done in the OR. Tube removal is done in the OR. All right, and that is it for those two chapters. Does that help? Okay. Let's get out your workbook. We have time to do a couple of the reports. Chapter 28, Radiology, page 185. Let's take a look at report number 46, number 58, report 46, radiology report, examination is biophysical profile, clinical symptoms, high blood pressure, estimated gestational age 28 weeks, 5 days. What are we going to code here? If she is 28 weeks, 5 days, what are we looking for? What are we testing? We're testing the fetus. So this would be a fetal testing. How are they doing it? If we're doing it in radiology, what do you think? Probably an ultrasound. So go ahead and look up fetal testing, ultrasound, biophysical profile. See what you come up with. Okay, Fran, what did you get?
I got 76818.
Anita?
Yeah, 76818.
Darcy?
I got 76827.
Shauna?
76818.
And Daniel?
76818.
Okay, so the difference here is that it is a fetal biophysical profile. But it's a non-stress test one. So because they're known specific findings, the biophysical profile was scored a perfect 8 out of 8. It was a non-stress test, so a 76819. And we want to use a modifier 26 because it was a professional component. Okay? Who wants to, actually we're all just going to do the ICD-10 code. What are we going to code for this particular case? It's a high blood pressure. What's high blood pressure? Hypertension. So where are we going to look? What's the hypertension doing? It is complicating the pregnancy. So it's hypertension, and it's complicating pregnancy. And it's also 28 weeks and 5 days. All right, what do you think, Daniel?
016.2.
Close. 28 weeks, 5 days. Shana.
I was gonna say 013.
Okay. Fran.
I got 016.3.
Okay. Anita.
Yeah, the same thing.
Darcy.
Oh, one. And the-
016.3.
Okay. So it is 016.3 because she's in her third trimester. And Shana, you were looking at the 013, which is the gestational hypertension without significant proteinuria. And that was not mentioned at all. It was just simple, the high blood pressure.
Yeah. Where did you get it though?
So high blood pressure, okay, hypertension. So let's go to hypertension. Okay, and then it is complicating. Why is it complicating? Because it's complicating the pregnancy. So over on page 1269 in your index. Yeah?
Yeah. Skipped right over it.
Yep. Okay. All right. Let's try number 60, which is report 48. Report 48 is an MRA of the brain. Third nerve palsy complete. So they did an MRI of the arterial vasculature of the posterior fossa and circle of the Willis region. So take a moment to read it, and then we'll take a look at what we have to look up. That one starts out real simple. It's an MRA. But an MRA of what? Okay, everyone had a chance to look for it. What do you have, Darcy?
I'm still kind of looking, but I'm thinking maybe 70554.
Close. Anita?
Okay.
Still
I'm
looking.
still looking.
Fran?
Oh, here. Yeah.
I got one and I have a question too. I think it's 70544. And is there would you put a 26 on the end of it? There's
Yes.
Okay.
Daniel?
Yeah, 705.
Reading.
Shauna?
I'm close.
Okay. It's 705,444 with a modifier 26. So, Darcy, look at why you chose 554 over 544. There was nothing in the report to indicate that there was including test selection and administration of repetitive body part movement. We simply have an MRA of the head without contrast material. If they use contrast, they will tell you with contrast. If they don't put anything, it's assumed it's without contrast. So, Shana, what got you hung up?
I didn't even know where to go to start looking. I looked at brain, I looked at
Okay, so
nerves.
MRA, magnetic resonance angiography. So go to the back of your book. M. And it's not fair because you guys haven't read this yet, but I'm getting you prepared. So magnetic resonance angiography, page 902, bottom left. And then what was it done of? It was done of the head. And then it leads you to code 70544 through 70546. You'll find that radiology is actually quite easy. All right. All right. Number 62, let's do report 50. This is examination of the left foot. Severe foot pain. Comparison is made with the most recent films available of 1015. There is diffuse demineralization of the osseous structures of the foot. Soft tissue swelling is seen. Erosive changes have been previously described involving multiple metatarsal phalangeal joints, and these are identified once again today. The differential is not significantly changed compared with the previous examination. So, for this particular one, report 50, we're doing a simple x-ray of what?
Left foot.
The foot, right? So, x-ray. X-ray of what? Foot. Okay, page 998 in your index, foot. X-ray of the foot leads you to code 73620 through 73630. So then you turn to that section in your tabular, 73620. Seven three six two zero. Radiological examination, foot, 2 views. Is that what they did? They said it's left foot. 2 views, left foot. So you could do it one of two ways. What's the other way?
LT or something.
And there's also a third way, because if it is a given fact that you are a facility that does x-rays right on site, you don't necessarily need to have the 26 modifier, the professional component. You can simply put the LT. You usually register with your payers what type of a facility you are. And by the payers knowing what type of practitioner you are, they also understand what you would be billing. It's also just very important that you make sure you are using the codes that they want you to use. So when you call to verify patient benefits for insurance, you would ask them, is this code covered? Does it require modifiers? So you could do it one of three ways. Okay? All right, let's take a look at chapter 29. We're going to pull one report from there. Let's do number 16, report 56. Report 56 is on page 244. This is an adenoma of specimen received was a cecal ascending polyp. They give you a gross description, microscopic description, and the diagnosis. So, for this particular one, now this is a path and lab. So, gross description, received in a container labeled cecal ascending polyp. There are 3 fragments of tan tissue measuring 0.3 and 0.4 centimeters in diameter. The specimen is totally submitted. Okay? So what is submitted? 3 specimens, right? So that's what you need to know, is the 3 specimens. Okay, so what did they have done?
Biopsy.
Cecum and ascending colon biopsies.
Well, that's the diagnosis, but what's the procedure? So,
Would it be a colonoscopy?
no, because this is a pathology report. So they checked the colon polyp. So microscopic description. The cecum and ascending mucosal fragments show glands that vary in size and configuration and are lined by uniform epithelial cells. Hyperplasia of the glandular and surface epithelium are prominent with serrated architectures evident. So because this is pathology, we're going to start in the pathology part of the index. Pathology. All right, and it's pathology of what? Well, how did they get the specimens? They had to perform some type of excision, which is part of surgery, right? So path and lab. So surgical. They had to do a surgical. Okay, page 929 in your index, in your CPT book. Surgical pathology. All right, and what type of surgical pathology? Well, they tell us that they used a microscope. So they did a gross and micro exam. So again, you guys haven't read these chapters, so I'm not expecting you to know this. All right, I'm just helping you kind of understand here. All right, so surgical pathology, gross and micro exam, what level did they do? Specimen is totally submitted. Cecum and ascending mucosal fragments show glands at varying size, hyperplasia. To 0.3, 0.4 centimeters. Specimen is totally submitted. We're going to have to go look at each one of those levels. So we start out with level 2, 88302. So let's turn to 88302. Okay, 88302, level 2, cervical pathology, gross and microscopic, and then it lists underneath what type they did. Does our cecal ascending polyp fit into any of those?
No.
How about 88304? Okay, go to the next one, 88305. Yes. You see polyp in 88305. How many did we have? 3. So, the correct answer for this one is 88305 times 3. Okay? All right. Homework. Okay, so next week I will email everyone to let you know, you two, where we're going to meet, if it's over at Mary Meeting or the high school. Everyone else, you just go to your directed locations. So next week, is chapters 29. Oh, how did we miss 28? We missed 28 tonight. Radiology. How did I miss that? Okay, so next week it was 28, 29, 30, and 31. And we'll be able to get it all done. So read all those chapters. Do your evolve exams. Daniel, what's your takeaway tonight?
Next chapter is going to be weird. So far in the book, I haven't seen anything like those before, and those lab reports. Well, not the lab reports, but the gross microscopic.
Yeah.
That stuff's going to be weird.
Pathology, yes. All right. Darcy, takeaway?
I don't have anything right now.
Okay. Anita?
Wait.
Yeah, I did understand, and
Okay.
I'm okay with that.
Fran?
I'm just getting anxious for the exam at the end. The big,
Yeah.
giant exam at the end.
Okay. Shana?
How many codes?
All right. So, reminder, have a great week. Thank you, everyone.
Thanks.
you.